Great, good afternoon again. Welcome to live case and lecture number 7. This is complex PCI. My name is Alan Yeung, and I am here with Jacques Koolen, and our panelists are Dr. Bai, Dr. Choo, Dr. Euswas, Dr. Hong, Dr. Lo, Dr. Ng, Dr. Suesat, and Dr. Voon, and Dr. Wu. This afternoon, we have a couple of live cases from Southeast Asia. One is from Malaysia, and one's from Indonesia. So let's go ahead and get started. Let's start with the linking to Rosli, Ali. Hey, Rosli. It's Alan Yeung here.
Hi, Alan.
Hi, how are you?
Hi. We are all good. Alan, Jacques, and the rest. We would like to congratulate TCTAP on their 30th edition for the meeting. It has been a great meeting all the time. And we are just pleased and honored to be invited as a live case center. So I'm here with Dr. Salvam, and I've got Dr. Fazeh here who's going to report on the OCT. We have quite an interesting case. This is a 58-year-old gentleman with triple vessel disease. He came with unstable angina in February, and he had angioplasty to the LED, circumflex, and OM then. And we wanted to stage the RCA's lesion for this live case. Next. So diabetic, hypertensive, and has hyperlipidemia. Next. His LV function is good, EF of 60%. Next. This is his recent ECG, again showing just Q waves in leads 3, but normal otherwise. Next. And this was the PCI that was done by Salvam on the 3rd of March. And you can see the OM branch and the distal circumflex, pre and post. Next. And that's the LED, again, long lesion, diffuse disease in the mid to this distal segment. And this had to be stented and with good results. Next. So here we are going to deal with this lesion. And I think you can just see in the diagnostic image is that there is calcification that's seen mainly in the proximal segment, but the lesion extends until the mid segment of the right. And this is a dominant right. At the same time, there's also severe stenosis in the distal, or rather mid PD branch. Would you just like to discuss amongst the panelists first before we go on and share with you what we have done?
Sure. So maybe we can open for discussion. So obviously, diabetic patient, three vessel disease, you can certainly consider, youngish person consider bypass operation, but has pretty bad distal disease as well. So anybody thought this is, in Asia, you would do PCI. There's no whole lot of question. But since we discussed PCI versus bypass surgery, is something that you would consider, Dr. Wu?
For me, because you can see that very diffuse disease. So the bypass, for example, this case in a proximal, the critical stenosis PDA. So, and also the proximal, you can see that before the RV branch, they have also diffuse disease. So for this kind of lesion, I would maybe, because of beyond that PDA also very diffuse. But I missed that the OM circumflex. So what about the LAD? Can we show the LAD? Because I just missed the LAD.
The LAD? Mm-hmm.
Can we go 2 shots behind, please? 2 shots behind, Prem. All right.
Okay.
All right, that's the LED there.
So the LAD also very downstream diffuse disease. So Lima, I don't know where to put because you have to be jumped between. And secondly is bifurcation. Of course, there was a good landing for the bypass, but LAD I think is downstream. For me in practice in Malaysia, probably with lesion preparation, DCB, the sizable PTM, maybe you can just fix it and maybe focal stent and maybe downstream DCB. I guess that's what I.
We do not have the full angiography pictures for the LAD, but it's a very diffuse with Lima will be put very far distal. So he had a bioadapter implantation in the mid LAD with a drug-eluting balloon distally. And I think, like you say, bypass grafting surgery will involve really distal vessels in the RCA and LAD. We might not be the best thing, I thought, for this patient.
The good news is that with PCI, what you have done is that you have not taken away the option for surgery later for whatever reason, because the area that they would bypass, you're not touching anyway. So, so I think it's a first choice. It's for this young man. It's not a bad idea to give him a shot. And also with all the modern medical therapy for diabetes and hypercholesterolemia, he could actually, if he can modify things like that. And so now let's focus to the right coronary. So that's your focus for the day. So how would people want to treat that? A very diffuse disease, PDA, some calcium. I'm not sure how much calcium there is. Since our last lecture, would people just go in and balloon it? What people do? Any comments?
Yeah, I think Rosli, Simon Lowe here.
Yes.
These are two experts on the monitor at the moment. I think one will have to go with an imaging to see the degree of calcification. I think as he's only 59, as Dr. Alan Yeung said, I think we must not delete this patient off the option of future coronary artery bypass operation. So the distal lesion, including the PDA, it looks like there's some calcium there, but I think if one can get away with a DCB without putting a stent in, I think that's a good option. But certainly the proximal to the mid RCA lesion, if it is very heavily calcified, IVL is a good option. It is a big artery, and I think finally one will have to stent that lesion. The question is how many IVL pulses are we allowed to shoot in this RCA? Yeah.
Maybe you will consider drug-eluting balloons, seeing a relatively young patient with diabetes, and for the peripheral small vessel, drug-coating balloon might be a solution. This is typically a point of discussion, these kind of patients that have diabetes relatively young. In a heart team, it's always the discussion, is it suitable for surgery or is it suitable for PCI? Both options are not very attractive. As just discussed, the Lima has little place to go, nor Rima. So you end up probably after a discussion with the decision of doing PCI. But even then, so you may have in the back of your mind that in the further future, bypass surgery might be needed, and then a distal distal part being stented is a kind of a problem for the surgeon. So I might consider to use in this relatively small vessel, at least for the distal part, a drug-coated balloon.
So Rosli, maybe show us what you have done, and
All right.
I
Can
think
we go to the
imaging
next
is
slide,
what
please?
we're asking for as well, whether you pre-dilate and looking at, getting some
Next slide.
detail.
We will show you the live images later, but can you go to the next slide? Simon, we have got a cheaper alternative to you than a shockwave IVL. We're going to use a mechanical IVL, and this is something new. We have had our hands on it last week. And next, please. And this is, next slide. And this is going to be a mechanical lithotripsy. And we are happy to say that we have been the first center in the Asia Pacific to actually use this. And we are going to use a Lytix mechanical lithotripsy balloon. And that's how we're going to do it, because we can see that it's calcified. We're going to image it. And instead of the normal, regular devices, we're going to use this balloon. Thanks. Let me just tell you something about the balloon, because it's something very new. So Hertz is a late 19th century physicist, and we had formulated this contact stress principle, and whereby this is applies the fact that there's a focal localized stress that develops when the curved sphere comes into contact on a plane, and in this case, the calcium plane, and it deforms it. So it is hard on calcium, but soft on tissue. Next. So this is what it looks like. So you have rows of small hemispheres made of stainless steel. In the 3035, there are 5 rows of 9, so that's 45 hemispheres, very small in terms of height and also diameter. Next. So what it does is that it is able to amplify the force. So at 5 atmospheres, it is equivalent to 60 atmospheres. And if you go up to 612, which is a rated burst, it can go up to 80 atmospheres. So once again, soft on tissue, it can potentially be able to crack calcium. And it's been shown in a study that it does well with calcium. Next. So let me just show you just a short animation on the mechanism of action. So there you have it. It is being inflated to about 5 spheres. This is just a cartoon. And it does act on the proximal. And in fact, in the study, the Pinnacle 1 study, and it also shows that it can also crack the deep medial calcification at the same time. So it's been suggested not to go more than 12. That's how it works in cracking calcium. Next. And this is just again to show that it works best in concentric calcification, but it does also work in eccentric and even in the calcium nodules, where at nominal pressure and at 2 atmospheres, you can have the calcium being fractured. So that's the the concept. If you don't mind, we just go on to the case first, and then we can then discuss about this technology later. Selvam?
So what I'd like to show is the live images. And if you can see, we took the next one. We took the images rather delayed so that you can appreciate the calcium that is there. It's deep, it is a big vessel. And we are not going to talk so much about the distal vessel. We have treated the distal vessel. It is not so small. We had to implant a 3 millimeter short stent, and we left enough room for future coronary bypass grafting surgery. So the next one, please. We are not going to concentrate too much on the distal for benefit of time. And I would like to show the first thing that we did is OCT images to look at the length. And my colleague, Dr. Al-Fazir, is going to show you the OCT images. And what we are looking for is the depth of calcium and the nature, the concentric nature of the calcium.
Okay.
Okay, thank you very much. Can you show the OCT images on the screen, please? We have started from distal to the RV branch. The EEL at that site is about 4.17. Can you see the OCT?
Yes. Yes.
Good. So as we pull back, this is our landmark, which is the RV branch, and you can see the EL is about 4, and you can see a lot of the fibrotic plaque and a lot of fibrotic lipid plaque here, and you can see the MLA as it gets quite tight, it's like 1.6. You can see also the arc of the calcification, so the angle of calcium here is like 200 degrees, thickness is about 0.75. And this segment here is about 5 millimeters from the RV branch. You can see it's very tight stenosis here. MLA is very small. 10 millimeters from the RV branch, you can see a very thick calcification. Angle is about 220 degrees. Thickness is 1 millimeter, so it's more than so it's a severe calcification. More than 180 degrees and more than 0.5 maximum thickness of the calcification. So it's quite diffuse. You can see the calcium goes throughout the proximal lesion. It's about here again 222 degrees angle, and this is about 20 millimeters from the RV branch. So you can see it's a severe stenosis with a severe calcification. Angle is about 180 to about 200 plus. Thickness is about 1 millimeter, on average. Okay.
So what, following the OCT, you will agree that this is heavily calcified, and the whole idea is so that we can modify this calcium so we'll have good expansion. So what you're saying now is, in order to advance this lithics balloon, we would like to prepare the vessel, and we used a 2 millimeter balloon to prepare the vessel. As you can see, 2 millimeter dilatation. You can see
we don't have it yet. Can you show us the angio?
Angio, please.
So what size guide do you need to deliver this balloon?
You can use 6 French. You can use 7 French. In this particular case, we use 7 French. I think with the 7 French, everything is a little easier. So here you see that we are dilating the vessel with a 2 millimeter at just nominal pressures, really, basically to facilitate advancement of the lithics balloon. Next. So what we did is to prove that we did not essentially crack most of this calcium with this balloon. So we did do a repeat OCT following the 2 millimeter dilatation. Could we show that?
So the OCT, again, our reference here is from the RV branch. You can, as we progress proximally.
We don't have, okay. Thank you.
You have it?
Yeah.
Okay, good. So now, let me start. This is from the RV branch again. So not much, as you would imagine, with a 2.0 balloon. there'll be some minute cracks here, maybe some small little speckles of calcium here. But it's essentially not much being done to the calcium as I go back up straight to the proximal here.
So proving that we did not really crack the calcium with the balloon, we can show the advancement of a 3.5 millimeter lithics balloon. At the moment, we do not have 4 millimeter, we have 3 millimeters. And you can see, can I see that? Yeah. So, well, I couldn't, to be honest, we couldn't really pass the distal, so we had to dilate distally with a 2.5, but we did not use the 2.5 for the proximal heavy calcified lesion. Following which, we were able to advance the balloon, and what we normally do is advance up to 5 atmospheric pressure and then hold it on for about 20-30 seconds. You need to do multiple inflation. The good thing about this is you can do as many inflation as you want and you are not limited. So what you're saying is at 5 atmospheric pressure, can we go back to 5? Yeah, so you can also see we did a, can I show that? Yeah, yes. So that is, what you can see is at 5 atmospheric pressure, you can see areas of dilatation, areas of poor dilatation, and you can see the hemispheres clearly on this on the picture. So can we show? So we gradually went up to 12 atmospheric pressure. Can we see that? So you can see that gradual enlargement, and then you can see a almost full dilatation. Now, although it is dilated fully, it is recommended, and that it's best that you do multiple inflation, changing the position of the balloon to allow the hemispheres to be in contact with different parts of the vessel in order to get the best maximum outcome. And what we would like to show you now is after multiple inflations, holding on to 20 seconds, and most of them at the end of it is about 12 atmospheric pressure, which is the rated burst pressure. And we would like to now show the OCT Alpha-Z. Back to you.
Thanks, Selva. So let's have a look at the OCT, please. So we start again our reference at the RV branch. As we move proximally, you can see some cracks here and go a bit more back. So there's a lot of fibrolipids here. And here you can see, so the arc of calcium, you can see at 2 o'clock and at 9 o'clock. The triangle here shows the thickness of the calcium. You can see cracks at the superficial calcium, but also cracks propagating in the mid-body of the calcification at about 2 o'clock here. So it's a very thick calcium, and as we move, again, you can see linear lines within the calcium at 2 o'clock. And again, so multiple cracks even here at the depth, the thickness of you can see the depth as well of the cracks here, the calcium. So I'm just going back towards proximal, and you can see multiple areas of cracks where it's superficial, and some areas at the medial areas as well. Mind you, the vessel is actually quite large, about 4.2 millimeters. Again, you can see cracks at multiple spots due to the concept of the balloon. Again, you can see cracks at the depth as well, 0.4 millimeters of calcification. Even at about 2 o'clock here, again, you can see quite a deep crack from the superficial going to the middle layer. So you can see multiple cracks throughout the calcification and advancing all the way up to the proximal right coronary artery.
So like in the Pinnacle study that they have noted the cracks, there are multiple cracks, and not only that, like Rosli said just now, that there's propagation of these cracks into medial wall. And now what we have seen that is that similar findings from the early clinical study, we are seeing that today in this live case of propagation of calcium. Once we are happy with that, we just continue with the angioplasty as you would normally do. We still go in with a non-compliant balloon according to 1-to-1 vessel size. And Rosli, would you like to?
The ideal use it will be 1-to-1 lithics balloon, but since they have only until 3.5, we use 3.5, and then we went on with the 4.0 balloon. Ideally, of course, I would actually love to use the 4.0 balloon to be able to just use one balloon and then correct it. So this is with a 4.0, and how high do we go? About
12.
14, I think.
14.
12 to 14. We didn't really have to go that much. Next. We measured this, and next. So here we are. We are at a point where we're going to place a stent in. And we just want to show you that, with the stent being implanted, we are able to get good expansion. And that is one of the benefits of this therapy. And if it does work, then at least we know that the stents are well expanded. And that's usually the problem in severely calcified, deep calcification.
But for this particular case, we are implanting a bioadapter, Rosli. As I'm sure many of you heard, bioadapter is literally 3 helical coils.
Rosli, one of the questions regarding this kind of lesion preparation, is it okay for DCB? Is it acceptable?
We have done DCBs, this week and last week, we had a number of cases DCB. But at the same time, we felt that there is, the vessel is quite large enough, and DCB is only 4.0. It might not be able to reach the calcium, the media very well. So we decided to put a stent in. And again, it's also to show that we can actually get good results with stent expansion. We use lots of DCBs on our site, so but this we feel should be a bit lower, please.
Yes. Yeah.
Should be with a stent. All right. Can we take a CD, please?
Yeah. So this is a bioadapter,
Right.
3 helical coils, which are bound together by 2 bioabsorbable polymers. The top polymer is PLLG, I think, and this carrying a limus drug, and the inner layer holds the 3 helical coils in place.
But one of the things you can see is that the stent is quite, the balloon is actually quite well expanded, but there's no waste. Okay, let's go down. And,
Any particular reason you choose this stent, or since you use Synergy down below, right? Didn't you?
Yeah, well, I
Number
think
one, that I suppose, is because it's a long stent, and and it comes off the band, so it's a good choice. Number 2 is that, of course, the Elixir is a producer of bioadapter, and they are also a producer of this lytics balloon, so it'll be just nice to put everything in.
more importantly, there are 2 large data that comes along. The first one is the bioadapter trial from Japan involving 400 over patients. Now we have 2-year data, and the 3rd-year data will be presented next month in Euro PCR, which shows for the first time the long-term outcome to be superior, followed by a large sweetheart study, 2,400 patients, and you can take a look at that result. First-year data is presented, 2nd-year data will be presented in the TCT meeting, and again, you need to go, this is not the best platform to talk about it, but you will see it's about reducing future events using bioadapter.
I'll be very interested to actually see the final OCT results and see the expansion. Because in the Pinnacle 1, can you stand this, please? In the Pinnacle 1, 90% of patients actually had good stent expansion. And, AACPI suggests that at least more than 80%. So that has been quite good. Yeah, a bit more, please. Stent boost, one more.
Rosli and Servan, hi, Gim-Hooi here. As you
Yeah,
have shown such great calcium modification, I just want to ask if you could share with the rest how you feel in terms of the deliverability of this balloon as compared to the ultrasonic electrolysis balloon.
Stent boost, please. I would tell you that it's good.
Yeah.
It is definitely better than a normal IVL, and you can go again and again. And I've, in our short time that we have had with this, it's been really good even in, in areas where there is tortuosity and so on. So it's been quite pleasing.
So 2 things that we found, that deliverability is really very, very good. And we have used it now over 20 over balloons, or maybe perhaps 24 balloons, and we have not had problems. Now, recrossing may be a bit difficult, but it is not as bad as we initially thought. An unwrapped balloon taking it out on a 6 French, you may have to be a bit more careful. If you're using Guide Plus and so on, And I think you should use a EL in order to facilitate easy removal of the balloon. So we've not had that problem at all.
Can I just ask, Rosli, what are the material? What's those
Stainless steel.
cannonballs material make of? Is it
Stainless steel.
Stainless steel?
Stainless steel.
Stainless steel.
But on the radio, in your fluoroscopies, I couldn't see anything. Yeah, it's like
Very-
it's
very
not
small.
radio.
You can't see it.
You have to
Can't
use
see.
stand
Stand
booth
booth.
now, and we did show. Would you want to
I
show
see.
the stand booth again?
How are these things attached to the balloon? Is there a risk that one of them may distally embolize when you deflate?
So, quite frankly, that was the very first question we asked them. And the bench testing, they of course, their technology, they do not want to reveal exactly how it is attached. But in the bench testing, it's never happened. And we have used 20 over in very, very difficult case.
Yeah.
Choo, you used it on an extremely difficult case, and we have not seen a single one come out. So we're fairly confident now.
Can you see the
Yeah.
rows of atmospheres
Yes,
on the
yes,
stand?
can see.
Yeah. Right.
And if you lost
Very
two of
small.
them, you won't know anyway, because so,
No,
so
no.
tiny.
Well, they assured us it has not happened anyway. So I think that it's how they, put.
Hopefully they'll count it again when you take it out. You have to count it back. How many? You just
Yeah. Well, I'd be lying if I said, yeah, I counted them.
But the interesting thing is to call it lithotripsy or mechanical lithotripsy. I'm not sure what mechanical lithotripsy means, because lithotripsy by definition is using sound wave to sort of sound to create, shock wave type of thing. So obviously
mechanical
marketing-wise
litho-
makes sense, but it is a different type of phenomenon, I presume.
Yeah, it's mechanical because with
No,
sound wave,
external outsource.
that's the ultrasound wave just to try to break, but this is by contact. And I
But
suppose
there's no external source to introduce power to break it. So it's
Okay, then you can see that results looks quite pleasing. Let's have a look at OCT and see whether we need to work anymore. The distal, we went up to 18 atmospheres with the same 4.0 non-compliant balloon, and proximally we went up to 20. Okay.
I might have missed it, but besides the novelty, what are the theoretical advantages of the mechanical lithotripsy versus the conventional one? Did you mention it, or?
yeah. So
Let's
so we did mention it. Now, number one, I think is deliverability. Number two, most importantly, they come at different sizes. Just give me 1 minute. I'll just take the OCT. Yeah. And then
pull back. Jack? Okay, pull. Oh, it looks quite nice.
Yeah.
Yeah.
So deliverability, but the most important thing, it comes in many different sizes from 1.5 to 2, 2.5, 3, 3.5, and eventually at 4. And you can use it many times as you want. And the other thing is it works for calcium arcs which are less than 180 degrees. And it does work for calcific nodules that we have seen. So yeah, that is probably the advantages, and reusing it, meaning in the same patient, in the same artery.
Yeah. I presume you just use it similar to an IVL balloon, because obviously this is not a primary balloon to cross uncrossable lesion, right? Because the profile is not going to be that small. So you would still need rotational hysterectomy to open up and unable to cross lesions.
Not really, Alan, because if you see just now, we managed to cross, and quite often you can actually do it by itself, most times.
Very nice.
But obviously, it is not the partnership for all calcified lesions. Sometimes it's very difficult, very severely calcified. You may have to combine technologies,
Yeah.
which I think is sensible. I don't think
Yeah.
we should say that this is the partnership for all. But certainly, it makes our work so much easier. It is less bulky than IVL. And even after you dilate, you can recross again.
Yeah.
And you just need to dilate with a 2.0. In our case, there was some resistance. We went 2.5 balloon, and then we could get it easily. And in fact, we tested it just now. We were wanting to show you that when we pull out, we push in with the used balloon, wing balloon, it still went in.
Can we see that?
Can we see
Can
the?
we see that?
Yeah, so this is from the OCT from the RV branch, or a bit just after the RV branch. Very nice expansion. So you can see the expansion percentage here compared to distal and proximals, over 80% to 95%, 100%. The MLA is about 10 or 11. Very nice expansion, going all the way up back to the mid and proximal RCA. Very nice. You can see the stent expansion is very good. It's 11. The MLA expansion percentage about 100%. Very nice. It's circular. The auto detection here says about 80% at this segment here, but otherwise, I mean, the MLA is 9, but otherwise, very good results. Yeah,
Very nice.
all the way.
Yeah.
So Rosli, remind me, how many hemispheres do you go up to? Is 12, you said?
Recommended rated burst is 12 because it's amplified by 6 to 8 times, so 12 is equivalent to 80 atmospheres.
What is instance of a balloon rupture, compared with a shockwave balloon? Yeah.
So far, what we heard is that they have done benchmark testing. It went up to 2024 without any rupture. Okay. I will have to, because we wanted to, in 2 cases, we had difficulty trying to order 3, that we cannot dilate, and we didn't want to take a very high other balloons because we felt that it's not going to give us good results. So we did go to 20 atmospheres.
Yeah.
It didn't fracture.
Yeah.
And then it gave way, and we were able to then treat with other stents or DCB.
Yeah.
I had 1 balloon rupture.
Yeah.
And that balloon rupture was because of previous stent that was jutting out, and the balloon was, I think, cut into the stent struts. Now, the good thing about this engineering way that they have formulated is that when the balloon rupture, it ruptures linearly, not focal, not circumferential. So when you have a linear perforation of the balloon, it is safe. So at least in that case, I thought it was going to be a problem, but no, it didn't. It just went away, and there was no problem.
Having said that, the caveats are that at the moment is not recommendation for use in the ISR lesions. So, and the recommendations are also not to go beyond 12 until you have done enough and you feel comfortable.
Yeah.
And
You didn't hear it from me. I didn't say more than 12.
Yeah.
Okay, so thank you guys for really excellent session to show us some new technology and this Lithrix new system. So thank you so much. We're going to move on to our next location. Again, thank you, Rosli, and
Thank you
for leading the team.
Thank you very much.
Take one shot.
Okay, so we're going to switch over to the Binawaluya Cardiac Center in Indonesia. The operator is Dr. Munawar. Hello.
Hello.
Can you hear us?
Hello,
Hi.
Dr. Yeung.
How are you?
Good, thanks. Thanks.
We have a esteemed group of panelists and moderator with us. So please introduce your center. I'm not quite sure exactly where you are in Indonesia, but maybe you can tell us a little bit and then your case.
Okay, thank you, Dr. Yeung, and everybody's panelists. Our center is actually located in Jakarta, and thanks very much for inviting me to be a part of the live cases in TCTAP 2025, and this is really our honor to be involved in this field. And before we are introduction regarding our case, may I introduce our staff here? And the second operator is luckily present. She is my daughter, Dr. Ati. And then my staff nurse is Lutfi. And then there are some of radiographer. And may we introduction of our cases here. It's very important. It's a very interesting case today. Darwin, can you show the case?
Hello everyone and welcome to this live case session on TCTAP 2025 from Indonesia. Today's case featuring complex PCI with a focus on bifurcation strategy. The patient is 75-year-old male presenting with stable angina CCS class 3. The syntax score is 20. He has a moderate bleeding risk according to precise DAPT and low on DAPT score. He previously underwent a primary PCI to circ due STEMI posterior with high thrombus burden. A thrombosuction and a single stent was deployed at the time. The electrocardiogram showed normal sinus rhythm with all posterior infarction. Chest X-ray showed no cardiomegaly and no sign of congestion. Non-invasive testing showed a normal ejection fraction with inferolateral hypokinetic. Lab shown elevated anti-pro-BNP and pre-diabetic. Now turning to the angiogram, we can appreciate that the left main shows non-significant stenosis. The LAD exhibit diffuse 70 to 80% stenosis from the ostium to bifurcation mid-segment Medina 111 with myocardial bridging in the distal part. The circ ostium has a moderate stenosis. The RCA shows non-significant lesion.
Okay, thank you. That's our case. So any suggestion or any comment regarding our case?
So the circumflex was the STEMI, right, back in February, right? So,
Yeah, 2 months ago.
and there was one stent placed proximally with a little bit of osteo-circumflex lesion that may or may
Yes,
not be
that's
significant once you kind of want to deal with the sort of osteo-LAD, but it sort of extends into the left main as usual. So panelists, what would you like to know about this particular LAD and circumflex before you proceed?
Do you have
comments from our panelists? Sorry, go ahead.
Dr. Munawar, Sunanto from Indonesia. Yes. Do you have any view for us to see the osteo of the LAD? Or we want to know the extent relation from LAD to left main? Thank you.
Okay, of course, yeah. So previously we think that the left main is not it's not significant lesion. I saw from the angiogram. Can you show me the first angio? Is it angio? Yes. Okay. So if you look at our angio here, that there is a significant it's before. It's significant at the proximal LED, and then you can see very clearly that calcification is proximal of the LED, and then there is a significant lesion at the bifurcation of the diagonal, might be Medina 111. And next, please, I think so. Yeah, if you look here, that the circumflex, no, before that. Yeah, I think it's I mean, there's this one. Then if you look here, that the ostial of the circumflex might be non-significant. I see that the flow is very good to the distal circumflex. Then any comment regarding that?
Do you have IVUS from the circumflex to the main stem and from the LAD to the main stem?
Yeah, well, I have already did FFR using True Visio. This is its new FFR. It's not using the pressure wire, but this is using microcatheter. So, but everything is quite similar with using pressure wire. And if you look here, that the FFR is quite normal. You know, FFR is 1, and we use with adenosine. So I don't touch the ostial circ. So next, please. So, you know, wiring to the LED is quite challenging, but finally we are successfully to put the wire until the distal of the LED. Next.
Can we see the full screen on the angio? We still see the FFR screen. So,
Oh yeah.
yeah.
Can you
Thank
see
you.
the?
Yeah, got it.
That's the FFR.
Yeah,
Okay.
got it. Thank you.
That's FFR. So again, that's next. Yeah. So can I see the IVUS? The IVUS, yes, we do IVUS from the distal part of the LED.
Yeah, let's see the IVUS of the LED.
Yeah.
No predilatation, or just this is de novo IVUS of the LED?
No, this is the de novo lesion of the LED.
Yeah, de novo.
The IVUS can go pass through quite smoothly, so we see that there is a lipid with a small calcification in the distal part here above the diagonal part here. This is quite superficial calcification because we can see the border of the vessel. However, this one is a lipidic plaque, quite significant there, and then in the proximal. However, we can see some third quarter calcification there with some nodule near the distal left main. With the MLA on the left main is around 8.2 millimeters square. So the tightest part is in the mid part of the LAD. So that's why we decided to do the rotablation on the LAD due to the nodule calcification, as you can see here.
Okay. So are you planning to do rotational atherectomy of this LAD? Is that what I heard?
Yes. But we think that it's only on the proximal part because we're afraid that if the rota touch the lipidic plaque here, could be make a slow flow of the vessel. Maybe you have any other opinions? Like here it's very tight and lipidic plaque, so we just focus on rotating the ostial and distal part of the left main.
Anybody would agree then do rotational atherectomy, or you would just ballooning? What would you do?
Well, I think there's in one part an almost circumferential calcification, so that's, in my opinion, a good indication for rotablation.
We should use that mechanical lithotripsy.
What about shockwave? Just simple, safe, somewhat more expensive compared with, of course, rotational hysterectomy.
Yeah, even though that IVL is available in Jakarta, I think it's still more expensive. And I show you that our approach is actually from distal radial. So you can see here that even though from radial here, but the IVUS can be done from between the leg, and then we do with rotablation, it's very comfortable. That's number. Number two is that the comfortable for the patient. For the patient, sometimes our patients look like sleepy or sleep, something like that, especially for complex cases, for long procedures. So this is we use with 7 friends. We are used with slender sheet, sorry.
Okay.
And this is very, very nice. Our default now is using distal radial.
Okay. So are you going to go ahead and do a rotational atherectomy? You put the
I
wire
think
through already, you exchange it out, or put a microcatheter?
We have already done with rotablation. Can you show?
Oh, you're done with the rotation, okay.
Yes, this is we rota the proximal part with 1.75. 1.75.
Let's play
Angio, please. Angio, please.
It's 175 per.
So this is very easy to do that because it's very short. It's actually, you know, if you look at the length of the calcification, it's only 5 millimeters, and then one nodule is close in the distal part of the left main. So we do it twice. One is with 190 RPM, and then the second we do with 150 or 160 thousands per RPM. So after this, we did. This is angiogram after rotablation. Then we do IPUS again. Can you explain the IPUS yourself?
Is there another run of IPUS?
IPUS, please.
Okay. As you can see here, we didn't touch this mid part of the LAD. It's still the same. However, in the proximal part, we see some reverberation a bit around this section. So we choose 1.7 this section. However, I think we do need a slightly bigger burr, might be, but however, we still decided to do another cutting balloon, not to advance upsize the burr.
So people would follow with the ballooning, or either NC balloon, or it could be a cutting balloon to make it bigger. Probably not go with another burr since you have 7 French guide. If you want to go up higher, it'll be a little bit tight, and so maybe just go with the balloon.
We can still using 2.0 burr. Yeah. But I think we stop with the 1.75, and then we use cutting balloon. That's the important thing for cutting balloon is that we want to have like controllable dissection, especially in the bifurcation of the diagonal with the 2.5 millimeters. Can we have angio, please? Angio.
For the full screen, okay.
Yeah, this is the cutting balloons before it's blue. Back. No. So cutting. This is cutting. So at the diagonal bifurcation, 2.5, and then we cut again at the proximal part with 2.5. Then we do cut again with the 3.25 at the proximal part of the LED, just like proximal part of the diagonal with the 3.25. Because in IPUS, according to IPUS, this is maybe about 3.5 until 4 millimeters. So with the 3.25 millimeters cutting, I think it's quite safe and it's quite good for that. With the pressure, it's about 10 to 12 or 14 atmosphere, and then this is the result of after cutting balloon.
Nice. What are you planning to do with the diagonal LED bifurcation? You plan?
Yeah, well, this is the length of the total lesion is maybe about 37, 38, 36, something like that. And then the distal parts maybe the diameter is about 2.5, but the left main diameter is about 5 to 5.5. So we can use one single stand, but I mean there's maybe I don't know whether any stand that's maximal expansion from 2.5 to be like 5.5. So our plan is actually to put 2 stand in. One is proximal 3.5, and then the left main maybe we can upsize until 5. And then the distal part, we put the DES 2.5 and then the pot with 3.5 of board. That's our planning.
Let's add on from the iris. The diagonal seems like there are no significant lesion at the ostial part. And we using cutting balloon, and we trying to avoid to put the wires in because of the controllable dissection there. So we not afraid to put the stand, even though we don't put any protection wire there.
Planning.
You don't place a wire in the diagonal just in case you have to go in there and that you know where to go. And I mean not for standing it or doing balloon or whatever, but just in case you gonna lose it, you know where to go as a guide.
Yeah.
No, in my daily practice, if the ostial of the diagonal is very severe, that's might be we need something like a protection wire there. But if this lesion, I don't put the protection wire. It is because of putting a protection wire is without the risk. Some risk might be perforation or might be trauma at the diagonal. So that's why in this kind of lesion, I don't put the protection wire.
Okay. So let's proceed because we're about 10 minutes left before we switch over to our
Thank you.
lecture.
So I put the proximal stand first. So 3.5, please. Yeah, 3.5. Yeah. Powder, please. Tiga setengah. Ya, oke.
Udah.
Tiga setengah. Ya.
Yes.
Ya.
3.5 times what kind of length?
Yes, 90. Yeah.
We did for the 5.0 in the last May. And then the second stand is 2.519, and then we did port like around 4.0 or 3.5 there.
Yeah. Come on. Okay. So the nominal pressure is 8 millimeters. Yes, please. Test.
Dr. Munawar, are there any methods you would use to land the proximal end of your stent at the ostium?
Yeah, I think it's at least we have to see from the orthogonal view, one from this and one from the cranial, epicranial. That's my favorite. Or sometimes we need a spider view. Yes, please. Yeah, maybe cranial, please. Okay.
So you're going to cover the left main, right? Is it?
Yes,
we cover until the left main.
Okay.
Spider, please. It's not very clear here. Agak lateral lagi. Yeah. Okay.
Not bad.
Any suggestion? That might be.
Did you have an aleocranial ready to look at the
aleocranial,
ostium? Of
Yeah, aleocranial, please.
Yeah, that's always
Aleocranial.
very helpful. This looks okay, spider.
Yeah, at least
In the
sometimes
neighborhood.
many views.
Yeah.
Okay.
Oh,
I think
this
it's
one.
the
Not the
spider
view.
is
Yeah, not very good view here.
yeah. Okay. Okay. Yeah. What? Mana? Spider, please. Okay. The nominal pressure is 8. Yeah. Okay. 9 times. 9 times. Yeah. Okay. Okay. Down. Yeah. Total. No, I'm missing one. So I did pot after put the distal stem. Cranial, please. Okay.
So we do like to do parts.
So how about
first.
the proximal? Put the proximal first. Is any
For this kind of technique, I prefer to use parts in the left main area to maximize the stent. Otherwise, you put a second stent through the under-expanded stent, it can be a problem because sometimes you would cut or maybe catch or that's or a squeeze of your unopposed stent in the left main.
Yeah. No. 3,5 tambah 5. 3,5 dulu. 3.5.
I think it's important that, obviously when you do 2 stents is not to end up covering the diagonal ostium with 2 layers of stent. That would be not a good thing. So sometimes it's easier to do it, proximal first and then so that you for sure are short of the diagonal
Can I
and then
have
you overlap with it. So
samples? Yeah. Okay. Yeah, I think it's okay. Yeah. Okay. Do what?
What size is this one?
2.5.
2.5.
19.
Okay.
No. Did you? That one. Okay. One more time. So that, okay. All right. Okay. Okay. Look. Look. Yeah. Different? Yeah. 3.5. Okay.
Okay. Okay, let's give us some angiogram, some views, and then let you proceed to finish up because we're going to have to go to our feature lecture next. So maybe take some pictures here and a spider view and see how things are.
Okay. Okay, before we are doing, so what we plan is actually doing pot, then pot at the diagonal, pot at the left main, and then iris. Okay, I do an angiogram. Okay. Yeah.
Maybe a spider. Take a look at the circumflex.
Spider.
Yeah.
Okay.
And then
spider.
Remove one as the. Remove one as the.
Yeah. This is 4 o'clock.
Pulang ke lateral sedikit. Okay.
Okay, so look about the same. Yeah, okay, so I'll let you finish up the procedure with your parts in both of the area, and thank you very much for illustrating this relatively complex calcified diffuse disease vessel, how you approach it. So thank you very much, Dr. Munawar. So thank you again for your team as well.
Yeah, thank you very much, everybody.
We're now going to have our feature lecture, Coronary Revascularization in 2040, and it is going to be given by Dr. Patrick Serruys. I think the title on the right side of the screen is wrong. So, Patrick, tell us what we're going to do in 2040.
Thank you, Alan, and thank you, Jacques. That's my consultancy. I think what is going to be impact coronary revascularization in the next 15 years is omic, genomic, lipodemic, proteomic. Also, polygenic clustering and AI will help to detect CAD, predict prognosis, and personalize treatment. Combined with non-invasive imaging, the so-called imagomics will help to document CAD anatomically and functionally to allow decision-making between conventional revascularization, PCI and CABG, and pharmacological revascularization through plaque regression and improvement in FFRCT, like in evaporate with icosapent ethyl. And of course, symptomatic biological and gene editing will help us to boost pharmacological revascularization, and the rate of mechanical revascularization may diminish, at least in the young patient. Now, over the last 10 years, we have seen a decrease in the global PCI and CABG market, and the trend will continue over the next 16 years. This is an academic and industrial projection of global PCI market. You could see from 2029, there will be a decrease of PCI, and you will see an increase, relative increase in DCB. The age pyramid will have major various and evolving impact on rate of revascularization in the different regions of the world. Young patients with non-calcified plaque and with flow limitation with soft focal lipidic content will be treated through plaque regression obtained with anti-atherogenic agent. In young patients, mechanical revascularization will diminish over time. In the elderly patient with calcified plaque with flow limitation impervious to regression, calcium must be broken, cutting, scoring, non-compliant, rotational, directional, lithotripsy, laser will prevail, and the mechanical revascularization will remain predominant over time. In the 90s, the motto of Marty Leon was "Stand them all." However, the metal-less era has started, and in 2040, the armamentarium will be a blend of various technological strategies: drug-coating balloon, drug-eluting balloon, high-pressure balloon, cutting, scoring, rotational atherectomy, directional, orbital, laser, lithotripsy, stent half metal, half biodegradable, polyscaffold in polylactide, stent in iron and magnesium, and bioresorbable scaffold with fibrillate supramolecule polylactide. Over the next 15 years, how will evolve the debate of a vulnerable patient and vulnerable plaque? How will evolve the debate between systemic pharmacological of local device treatment? That's the ménage à trois. Will angina be perceived as less detrimental in terms of prognosis? That's ischemia trial and Scott Hart 2, and be less aggressively treated by mechanical revascularization? Or will bad physiology, FFR, IFR, and other, will be perceived as more detrimental in terms of prognosis? That's the Lens-Gould view, and are treated more aggressively by either pharmacological or mechanical revascularization? Or will plaque burden and high-risk lesion become the predominant factors in vital prognosis? That's the new vision of the CAD RATS consensus and ICFA, and I will come back on that. In Emerald 1, 10 parameter has been described for the high-risk lesion, and it's a never-ending debate between vulnerable patient and systemic pharma treatment and vulnerable plaque and focal device treatment. And 20 years of trials on vulnerability will be pursued to prevent worsening the nest. never-ending debate. Artificial intelligence for quantitative coronary plaque and hemodynamic assessment. The term is ICFA. It's a consensus term adopted by HeartFlow, clearly and elucid, will become omnipresent after the Emerald-2 5-feature for identification of AS culprit lesion has been identified. Delta FFRCT, plaque burden, total plaque volume, low attenuation plaque volume, and average percent total myocardial blood flow, a novel parameter of heart flow. In 2040, the next generation of cardiac MRI will become more and more like CT, while the next generation of CT will become more and more like MRI. 30 minutes of MRI, you have a stress perfusion, cardiac function, and the late gadolinium for infarct area. But I'm sure that in 2040, MRI coronary anatomy could be reliable. That's the pictures of MRI 25 years ago by our team at that time in Rotterdam. And clearly, non-invasive MRI hemodynamic with blood pressure will provide you with pressure volume loop, pre-intervention and post-intervention. And we look now to streamline and vector of velocity. And with Galway, Toronto, Melbourne, and Cedar Sinai, we use multi-slide CT scan hemodynamic assessment of aortic regurgitation post-TAVR, also on streamline and vector of velocity. Let's shift gear. In 2040, we will have a new way to think platelet inhibition. We will have metallic and polymeric device semi-covalently coated with biomimetic CD31, a trans-homophilic for endothelial cell and trans-homophobic for platelet and leukocyte. This 20 amino acid of CD31 is grafted, coated in the stent, and the CD technology provides a camouflage layer that mimics a healthy endothelium, bluffing the platelet and the leukocyte, who have nothing to do since the metal looks like a perfect endothelium. And you see our early preclinical work show complete endothelialization in 7 days without the presence of thrombus. That's the work of Giuseppina Caliguri, Research Director of the INSERM in France. In 2040, conventional invasive coronary angiography as a diagnostic tool of CAD will have left the scene. But today, how do we do the triage of the CAD patient? We use AI remote anamnesis. We do the pre-test probability recommended by the European Society of Cardiology. And then the multi-slide CT scan is used as a luminogram, vessel composition, and hemodynamics. That's the one-stop shop which gives you CT angiography for stenosis detection, ejection fraction, wall motion, fractional flow ratio for the epicardial conductance, microvascular circulation, myocardium at risk, and hologram measure for the graft length. The conventional CT gives you some tissue composition, but the photo counting today provide new phenotype plaque. This is what we have just published a few days ago. You see low attenuation surrounded by calcium, and in histopathology, indeed, we saw deep calcium, superficial calcium, and necrotic core in between as a sandwich. And I almost forgot the inflamed perivascular fat, which became every day a little bit more important. Now, clinicians start to use machine learning on their smartphone to predict MACE and death. And clearly, when you have this one-stop shop, you can move directly to the cath lab with a carefully planned coronary intervention based on pre-existing information. You can move directly to the operating room without conventional CT angiography, or you can start an aggressive primary prevention. This is a case that we did last year in the PCR. We were selecting the guide after measurement of the sinus valsalva, 2.88 centimeter, We were selecting upon the device because the main calcification at the end of the main stem with lithoptistry up front. We were selecting the angiographic view for intubation of the left main in LAO 20, CRA 30. We were selecting for the optimal angle of the left main before the procedure. And we were also selecting the stent length and diameter and the pot. And you could see with the planner software, the virtual treatment, basically what was red here has become blue, and only a secondary branch of the diagonal branch is still ischemic. Virtual reality in the interventional suite is reality. This is an analog OCT post-DCB merged in the reality of the cath lab. You have the hologram of the OCT in front of the operator hovering in the cath lab, and you can have a flying through, and all the desired measurements are superimposed on the hologram. Now, clearly, more and more we will stay away from the radiation. Force is the fiber optical real shape. It's light instead of X-ray to steer the guide wire. The guide wire has 4 microfiber, and when you bend the guide wire, the speed of the light is changed and the resonance is changed. So what you get is the 3D visualization. Here is the catheter, not the guide wire, and you could see that without fluoroscopy, we can follow on the screen the bending of the catheter. You can make a double loop, and instantaneously you will see the double loop on the screen without without X-ray protection and without the fluoroscopy. And then once you have done that, you can, So you have seen that. I will push a little bit forward. But you see the bending, and then I will show you the overlay that you can do on the multi-slide CT scan, or you can do on the fluoroscopy. Once again, the loop down in the catheter, all that because you handle the microfiber in the catheter or in the guide wire, and instantaneously you have the motion, the three-dimensional reconstruction of the guide wire. So let's see the next sequence. This is a leg, an overlap, and you see the guide wire making progression, and you do that without using a fluoroscopy. Now, in 2005, a robotic magnetic cath lab was installed in the Thorax Center in Rotterdam. In 2040, young cardiologists will no longer be exposed to X-ray beam and orthopedic damage, and will play video game in the interventional suite. You see the magnet moving the tip of the catheter, which has been magnetized. I've been impressed by the surgical robotic, and as a matter of fact, we should copy the surgeon. This is the first heart transplant in Riyadh. You could see the surgeon cutting the aorta, the pulmonary artery, the right atrium, the left atrium, and finally pulling out the worn-out heart through a small orifice of 7 centimeter. You see pulling out the heart, and then what is going to happen is that in the next sequence is introducing the new heart through the small orifice, and again suturing the aorta, the pulmonary artery, and the right atrium and the left atrium, and all that to a small intercostal incision of 7 millimeter. Now, it's clear that for the surgeon, what was a first in man in 2024 will be a routine in 2040. This is a paper that we published in the European Heart Journal last year. That's the first in man. Coronary bypass surgery guided solely by computer tomography in the low-risk population. The surgeon didn't have the conventional angiography, and they were able to operate the patient with 99 feasibility and a patency of all the anastomos of 92.6%. So you can predict that in 2040, conventional coronary angiography prior to CABG will no longer be performed. And with the sole guidance of a new generation of CCTA, decision-making in favor of surgery, PCI, or pharma will be made routinely by the heart team. CCTA, as a game changer, may change the gamekeeper of the mechanical revascularization. This is the heart team new style in Galway. We see the surgeon explain to us what he's going to see. We see the hologram on the screen, but he can see us through the goggles, to the virtual glasses. And at the bottom, you see I'm measuring the length of the bypass who has to be harvested by the surgeon on the hologram. This is the work that we have done with Puskas. He's an extraordinary surgeon. You see here 5 arterial anastomos, the rima prolonged by the radial artery on the PD on the posterolateral, and the lima on the side of the lima, a radial artery going to the obtuse marginal, and then a connection with the diagonal and the LAD. And we control all this work 30 days later. But not everybody can make 5 arterial anastomos. So we have been working on biorestorative, biodegradable grafts. You see here in 2040, coronary bypass graft made of electron-spun fibrillated microfiber of biodegradable supramolecule will be available on the shelf in the operative room and will eliminate the cut in the legs of the patient. You see the matrix of microfiber made of supramolecule with some nitinol here, and you could see the biodegradation process. And Renu Virmani, we just published that together. The Renu Virmani see the scanning electron microscopy, the endothelial cell, also in transmission, and they are all von Willebrand positive. You could see the evolution of the graft over time in the animal. This is preclinical work in the sheep showing the bypass on the LAD, which has been ligated. And the important thing is that the first in man has been done. This is the bypass graft on the trifurcation of the right coronary artery, which is now totally occluded, and the PD and the posterolateral branch. Now, I have to tell you that the next tidal wave is the photo counting. And the photo counting detector CT will accelerate the disappearance of the coronary angiography as a diagnostic tool. That's the next tidal wave. So you could see here conventional CT with a blooming effect of calcium, unsharp contour of low attenuation area. This is high-resolution software, less blooming artifact clearly, but disappearance of the low attenuation area. And this is the photo counting scanner. You can see very sharp contour of the calcium, but the low attenuation is perfectly delineated. Photo counting scanner can clearly visualize stent strut by struts with a resolution of 111 micron. CT photo counting allowed a 3D reconstruction of the stent and visualization of the metallic carina of two-stent bifurcation. Clear delineation and quantification of lumen stenosis, easy quantification of diameter. Now, this is an image which is quite unique. You could see calcium superficial, calcium in the depth, and the interconnection. You cannot see that with the IVUS because you have the shadowing effect. And this is a total occlusion. You can see the soft proximal cap. You can see the very low attenuation, probably thrombotic. You can see the low attenuation, and you can see the soft distal cap. It's clear that it will be a piece of cake for recanalization. Now I'm finishing by the next step, beyond the tidal wave of the photo counting detectors. Let's have a glimpse into the future with hierarchical phase contrast tomography, going from microscopic volume rendering to microscopic morphology. You will see the heart of a lady, 87 years old, with a stent in the LAD, an inferior MI, dilatation of the mitral alienus. Let's look for a volume rendering. This is the volume rendering. We are going to go through the fat and discover the coronary artery, but also the venous system. You can see the secondary, tertiary, quaternary side branch of the coronary artery. And if you look carefully, it's amazing how the fat has lifted away the coronary system, and you could see all these small vessels, pre-arterial and arterial, 400 micron, literally plunging into the myocardium. This is an image that I have never seen, and it raises a new concept. Can you have an increase in the microcirculation just by the compression of the vessel to the fat? We can keep going to looking at this heart in great detail. We can go through the myocardium, see the area of ischemia in black. You will see in a second. This is where you have some ischemia in this heart. Here, the scar of the tissue, the chordae, all the valve, all the structures, back and forward. Again, this. So this is this patient. This is the stent with the calcium. Have a look at the RCA with a resolution of voxel of 20 micron. So we went for 400 micron to 20 micron and heaved 2.2 micron. And you could see here in the cross-section of this right, the adipose tissue, the adventitia, the wall, the lumen. And here you see in this frame in red, you see two small nodules of calcium with speculated aspect. So this is image which are phenomenal. Now it's time to conclude and to tell the truth, all the truth, but the truth. I misled the audience only in this last topic, and I must confess, it is a postmortem heart. It is fixed in glutaraldehyde. The impinging photon is accelerated linearly by a synchrotron. And we had to go to Grenoble in France to get the synchrotron. And the heart was in a tank 170 meters from the cyclotron synchrotron. And we have to rotate the heart in the tank. So that's what it is. But in conclusion, what I used to say to the fellow in the department is that if the future is unrealistic, fortunately for us, it will remain the future. But if the future is realistic, sadly enough, it will soon become the past. Thank you very much.
Thank you very much, Patrick. Any comments for Patrick? Hopefully by that point we've cured the disease, right? We should have no need for revascularization.
Yeah.
What do you think?
You know, it's interesting that the surgeon, one of them is Torsten Dunst, is a surgeon. He doesn't speak anymore about revascularization. He's talking about cardioprotection for vulnerable plaque ruptures. And it's true that in this population of 114 patients that we have operated without conventional cine angiography, we have been looking at the presence of vulnerable plaque in the segment proximal to the anastomose, distal to the anastomose, and in the vessel that the surgeon did not treat it. And it's amazing to see how much is in the proximal segment, but that was well known by Rick Kunz and Laura Mori many years ago. So I think that the concept may change at the time, and it's true that spontaneous myocardial infarction is nicely reduced by surgery.
Excuse me, may I ask, thank you for great lecture. May I ask your comment in the future, 2040, how about the individual or personalized care for heart disease? How about your comment about individualization, like the prediction or genetics to predict about the heart disease in human?
Yeah, I think it's moving very fast. I mean, if you look at the last European Heart Journal, there is an editorial of Filippo Crea, and the whole issue is about predicting. I think at the age of 20, you can more or less predict if you are going to be diabetic, hypertensive, and all these things. You know, we discovered at the end of the war in Korea, the GI, the anatomy on the autopsy of the GI show plaque at that age. Now we discovered that by multi-slide CT scan. So you have to say something about it. You know, with gene editing, one single injection, changing one letter in the alphabet of the DNA, and your LDL cholesterol go to 50 for the rest of your life. So that's coming. There's been already 13 patients. It was stopped. It restarted because the molecule to fix on the liver was not perfect. But now we use the molecule of the inclisiran, and there is no enzyme and nothing. So it will start again. And the gene editing will be there massively. So I believe that my generation has to be cracked with calcium. But I think that the young generation can benefit of all these things. So it's, in a dream, you could see that after the Second World War, basically the antibiotics has eliminated a great deal of infectious disease. I think it might take 1, 2, 3 decades to get the same with atherosclerosis.
Thank you again, Patrick, for excellent and very helpful lecture look in the future. Thank you. So we'll wrap up this session of Complex PCI. Thank you so much.
Thank you.